Hello, and welcome to this PowerPoint presentation. Over the next 10 minutes, I'm going to address the issue of whether doctors sometimes provide more care than their patients need. So do doctors care too much? Primum non nocere is a Latin term meaning first do no harm, and is one of the foundations of the Hippocratic Oath, which physicians take. Essentially, it's translated into making sure that you do not over-investigate or over-treat your patient, which may potentially harm them. So what evidence is there to suggest that over-investigation and over-treatment of patients exists? Looking at the literature, this recent review, a meta-analysis by Morgan et al. In JAMA Internal Medicine, looked at over 800 articles and certainly found evidence to suggest that there may be medical overuse, both in terms of over-investigation and over-treatment, and that this may result in patient harm. The review by Morgan et al. Looked at specific cases of over-investigation and over-treatment, such as the use of procalcitonin as an investigation, which did not actually reduce the use of antibiotic use by practitioners. Similarly, there was found to be an overuse of opioid medicine prescription for non-cancer related pain. One area of particularly one area also that was found to be important was the high percentages of so-called incidentalomas. These are abnormalities found incidentally when imaging for non-related issues. These were found to occur in certain settings in a particularly high rate. In fact, in the setting of CT coronography, there was nearly a 40% incidence of incidentalomas. There is therefore evidence that over-investigation and treatment of patients may occur, and that such over-investigation may actually be harmful to patients in specific situations. But if this is occurring, what are the potential drivers which are actually forcing this? It is likely that these are multifactorial in nature. Certainly, there is an increased pressure on physicians to see a greater number of patients. Physicians that may therefore over-investigate patients in an attempt to not miss things that could be a problem for the patient at a later stage. Likewise, there may be incentivization of physicians to order tests and treatments, including fee-for-service payments, or also health insurance metrics, and this may also contribute to over-treatment. Another potential important driver of over-investigation and treatment of patients may be the practice of defensive medicine. Defensive medicine is defined as medical investigation or treatment which does not directly benefit the patient, but is practiced with intention to prevent possible future legal action or litigation. This is likely something that's increasing over time as the use of litigation against physicians increase. Medical practitioners may therefore exceed what is generally necessary for diagnosis and treatment to avoid missing what may be an unlikely but possible condition. As mentioned, this is likely to be an important cause which is going to increase again in the future. Another form of defensive medicine may be that practitioners undertake procedures and investigations that the patients themselves demand or expect, even if not felt to be clinically necessary, and this may be performed in order to satisfy the patient. Medical over-investigation and treatment by physicians may also be practiced to avoid risk, and this in some ways is another aspect of defensive medicine. This may also have the knock-on effect of actually avoiding treating high-risk patients in case of complications including operative mortality or morbidity, which may lead to future medical legal claims. As a result, there may be a so-called cherry picking, where physicians practice medicine or investigation on patients who are more likely to have good outcomes and avoiding those patients that may be higher risk with multiple comorbidities. In fact, such patients who may stand the best, who may actually stand the most to benefit due to having multiple comorbidities, may actually be denied potentially life-saving procedures. It is likely that such practice of defensive medicine may increase healthcare costs and pose a significant risk to the patients. So how do we get the balance right? How do we prevent over-investigating and over-treating patients, but at the same time trying to ensure optimal treatment? Physicians sometimes feel that they're in a catch-22 situation when they're told they may be over-treating patients. However, when a diagnosis is made, they are often held responsible and blamed. Clearly, if we're to treat this, then medical education, and particularly the use of practice guidelines, may be important to guide physicians to undertake the appropriate investigations and treatment for their patients. In this regard, National Institutes for Health and Clinical Excellence, NICE, is an important independent organisation in the UK which is responsible for providing guidance on medical conditions. Specific NICE clinical guidelines give physicians recommendations and then allow patients to undertake the appropriate investigations and treatment of their patients on the basis of best medical practice. Not only do these guidelines reflect available medical evidence for efficacy, but importantly also incorporate cost-effectiveness metrics, which are important for physicians, health service managers, commissioners, and the health service as a whole. In line with this, if we want to reduce over-treatment and investigation of patients with defensive medicine, really we need to share the burden. In line with this, there are many practical tools now that can help physicians make difficult decisions and may reduce over-treatment and investigation. Increasingly, MDTs are used. These are groups of specialists that discuss complex patients, and this makes sure that patients receive the most optimal treatment for their condition. And this also reduces the burden of difficult and complex decision-making from a single physician. In fact, it is fair to say that MD discussion is now becoming the norm, certainly for complex patients and procedures. If we look to the private sector, often MDT discussion is mandated before certain complex procedures are authorized by insurance companies. It is hoped that with such sharing of the burden and with MDT discussion, that best practice can be performed and patients do not undergo unnecessary procedures with little benefit and potential risk. Another important aspect is the use of shared decision-making, whereby both the patient and the physician contribute to medical decision-making processes, and this is increasing in the future and is likely to increase even more. The patient is key in terms of the decision-making process, but should be made aware of all the potential treatment options, the pros and cons, and the risks associated with treatment. In conclusion, although there is evidence that there may be over-investigation and over-treatment with patients, as mentioned previously, this is likely to be multifactorial. Clearly, a balance needs to be struck to ensure patients receive appropriate and timely investigation and treatment. But at the same time, it's important that we support physicians in their decision-making processes and also protect them in the event of unforeseen circumstances. It is likely that the use of clinical guidelines, decision-making tools, and shared decision-making processes will improve patient care and hopefully avoid unnecessary, expensive, and potentially harmful treatment to our patients.